Welcome to my YouTube channel. Today we are going to talk about clinical features of preeclampsia. Kindly make sure you subscribe. It will cost you absolutely nothing. Preeclampsia clinical features. We are going to divide this in a very systematic manner. We are going to deal first of all with the maternal features, and then now we are going to deal with fetal features later. So the first one is weight gain or edema. And just to elaborate this, we say that you are going to have extravasation of the fluid from the intracellular to the extracellular. So this is one of the great contributing factors that you are going to have weight gain and edema. So this is one of the earliest signs of preeclampsia. And as I said before, this is due to extravasation of fluid secondary to increased capillary permeability, and it may also manifest as an increased hematocrit due to hemoconcentration. So while preeclamptic patient may have an increased total body fluid volume, they are relatively intravascular volume depleted due to the extravasation of fluid. So we have two spaces, the intravascular and the extravascular. So what happens in preeclampsia, because of increased permeability caused by inflammation and cytokines, then we are going to have fluid moving from the intracellular space to the extracellular space. Kindly note that if you meet up this patient, then the first thing that you're going to have to do is resuscitate in terms of fluid, because already we have intravascular volume depleted. So we continue the clinical features, with the maternal clinical features, where you're going to have systemic hypertension, and this is because in the pathophysiology behind preeclampsia, you're going to have ischemic, placenta ischemic, and that is going to produce toxin into the bloodstream, causing vasoconstriction, causing increased permeability, among other factors. So you're going to have widespread vasoconstriction, and in addition to that, that vasoconstriction is going to increase the peripheral pressure, vascular resistance, meaning the diastolic pressure particularly will be affected because of that. So diastolic pressure is particularly affected as it is more closely reflects the arise of peripheral vascular resistance. So that one is renal impairment. Also note that we are going to have widespread vasoconstriction, so it is occurring even in major organs. So vascular arterial vasoconstriction, glomerular arterial vasoconstriction results in decreased glomerular filtration rate. So if you have decreased glomerular filtration rate, then you are going to have oligouric, that is small urine, or even anuria, that is no urine at all. So altered glomerular capillary permeability also results in proteinuria, and that's why we said one of the definition of preeclampsia is when you have elevated BP of 114, 190, or when in addition to that you have proteinuria or severe features of preeclampsia. So the other one is coagulopathy, and as we noted in the pathophysiology behind preeclampsia, you're going to have increased platelet aggregation among those factors, and this is due to thrombocytopenia most commonly, and you can also have disseminated intravascular coagulation may occur as well, especially in the context of placenta ablation, complicating preeclampsia. So the third one is liver impairment. We say that you're going to have widespread vasoconstriction. So systemic constriction results in ischemic damage to the liver, resulting to focal hemorrhages and infarction. And these usually present as right upper quadrant pain or epigastric pain, and rarely you can have an hepatic rupture. So in terms of neurological impairment, this vasoconstriction is going to go to most organs. You're going to have visual field disturbances, new onset headache, hyperreflexia or clonus, seizures, which we said, seizures when you have preeclampsia and now accompanied by tonic-clonic seizures, not attributable to any other causes of seizures, then that is eclampsia. In addition to that, you're also going to have cardiopulmonary impairment, where you're going to have pulmonary edema. So in terms of symptoms, it's just a kind of repetitions of what you have talked about in clinical features, or just simplifying the visions without the pathophysiology. So the mild symptoms, as we talked before, we are going to have slightly swelling over the ankles, that is the edema, and gradual swelling extending to the face, abdominal, vulva, or even the whole body. And alarming symptoms, these alarming symptoms are mostly neurological, liver, and kidney, where you're going to have headache, which could be frontal or occipital, disturbed sleep, diminished urine output, which is said could be anuria or oliguria, and less than 400 ml per 24 hours. Eye symptoms, which you could have blurring or dimness of vision, and epigastric pain, which I've really explained the pathophysiology behind it. So in terms of signs is what you see. you as a clinician, you're going to note abnormal weight gain that is greater than 2.2 kgs in 1 month or 450 grams in 1 week. In addition to that, persistent rise in BP, that is more than 140 to 190 millimeters of mercury. Visible edema, as we've talked about, over the ankles, hand, face, from the rise of the bed at the morning. Also, signs of pulmonary edema, abdominal examination will reveal epigastric pain because we said we have liver involvement. In addition to that, you're also going to note when you're doing an obstetric examination, you're going to note scaty or intrauterine growth restriction. This is because of chronic placenta insufficiency. So in terms of systems, we have a very good summary that's in this table. So CNS, you're going to have eclampsia. As you see, this is when you have generotonic seizures that are not attributable to any other causes. You can also have hypertensive encephalopathy, intracranial hemorrhage, cerebral edema, cortical blindness, and cranial nerve palsies. In terms of renal, you're going to have reduced GFR, as we talked before, proteinuria, increased serum uric acid, creatinine. So if you're going to have this, then you're also going to have if you're going to have reduced glomerular filtration rate, meaning that you cannot filter things, then you're going to have increased serum uric acid, in addition to increased creatinine, increased urea. And you're so because you have reduced glomerular filtration rate, you're also going to have oligo and anuria, and that will predispose the patient to have AKI. So acute kidney injury. So in terms of liver, epigastric or right upper quadrant pain, as we talked about, you're going to have abnormal liver enzyme where you have the capsule or hematomas, and it ruptures, then you're going to have hepatic capsule rupture or HELP syndrome. So in terms of hematology, we have discussed this just as a summary: decreased plasma volume, hemoconcentration, thrombocytopenia, hemolysis, and DIC. CVS, we said pulmonary edema, pulmonary embolism, future hypertension. In terms of placenta, we are going to say intrauterine growth restriction, placenta abruption, and intrauterine demise of death. So in terms of placental fetal manifestation, it's just a repetition of what we have talked about. And just to repeat what you have talked about in the previous layer, because we said we are going to have chronic placental insufficiency, then we will have intrauterine growth restriction, intrauterine growth demise, and few liquor, that is oligohydramnias. So intrauterine growth restriction, which is usually asymmetry, intrauterine fetal demise, that is demise, oligohydramnias, and then you can have placenta abruption.